hear us?
Yes.
Still no audio?
Oh, now there it is. Yeah, there you go.
Okay. Can you speak too, just so I could see?
Oh,
It's okay, it's okay. Vivi, if you're there, can you just unmute yourself for 1 second, just to make sure that we can hear you?
Okay. Can you hear me?
Perfect, thank you.
yeah.
All right, I think we're all set now.
So he's gonna speak from the desk.
I don't know.
Oh,
I think he's coming
I think he
here.
said he was coming up.
Yeah, I think he was coming up.
Hi.
Hi,
Wait, you didn't know my life.
I know you were busy today and I was busy too.
I'm all the way back here like I could. He has to be on the board though, right?
I don't know, is he?
Yeah, he has to be on the board.
Okay, then let's try to move on with this side then,
He has to be on
if
the
that's
board.
okay.
He's gonna do exactly what Dr. Williams said.
Okay, great, then we'll just set it up.
Because
then.
he's here live.
Okay.
Right?
Yeah.
That's the only thing. How you doing, Allison? Good, how are
Okay, Can we
you?
move all the chairs over here then, Rush? That way it's more like he's presenting.
That's what I'm thinking. If I'm wrong, please don't be mad that you guys moved all these chairs. The only thing.
The
that-
camera's right there, don't forget, so you gotta move them over here this way. Yeah, like all the chairs are here, like just make them like this, more like a, yeah, there you go.
That's what I'm thinking.
You might be right. There we go.
and then we'll begin.
It'll just be like two sections, yeah, 2 rows, yeah, does that make sense?
I don't need it. I'm just kidding.
It's just the knee, it's just the knee, no big deal.
Not too low.
I got 2 of them. This from you, that. This one over here.
I just said a board needs to be one.
What's that?
It probably just needs a good bath. I think if they put some soap and water on it, it could go back white. That's what I'm thinking.
Have a seat.
I'm so hungry, I can cry. They waited to find you.
I know, I saw Diana's text coming through, I'm sorry. Okay, I think that's about as good as I can get. We're back, I'm gonna put this.
You didn't use the board, right?
Yeah.
Okay, that's what I was thinking.
Okay.
No, because everybody was trying to sing around the table. I'm like, I think he's probably gonna write the board.
Yeah. Okay, we'll give it a couple minutes. And then we'll do it. This is our third talk, I think. A lot of you, this is like, we done this a lot of summers, I think, some of this repeats, but any of you guys were like summer school last year, mostly new. Yeah,
Everybody here probably this is their first class.
okay, that's good. Okay.
Might have to bring in some chairs.
Yeah, you can sit on this side too, okay? And they can see the board on the screen, looks like. You can change the camera more to it.
Yeah, I tried to aim it as good as possible, honestly.
Okay. All right. I think anyone else is coming from out there?
They might drink oil.
All right, so you had a talk so far, Dr. Williams spoke about the menstrual cycle, which is like really critical to everything we do. The more you like learn about the menstrual cycle, it seems so simple, but the more like everything and recording day one, finding treatments, variations we do in our treatment. So that he probably went through, wasn't able to make it this year, but I heard it before. It's really great if I think Sophia can, or at least it could show you how to access either that one or last year's in SharePoint. But looking at those curves of like the hormone levels, the follicles growing, it's really useful. And all the treatments we do, most of them revolve around that. So it's hard to understand IVF without having like some understanding of what the normal, like natural menstrual cycle is like. And then kind of went a little bit out of order. Like Dr. K spoke about genetics and pre-implantation genetic testing, that comes later. You have to do in vitro fertilization to get to that. So I'm going to give a just brief, hopefully 30-minute overview of IVF, in vitro fertilization, which is not the only thing we do here, but it's our most advanced, most effective fertility treatment, most complicated, involves all of our teams. We have people here from andrology, embryology, nursing, care coordinating, chaperones, doctors, physicians. We need all of us to like get all these pieces to work. So I'm going to try to simplify and focus on some important things. It could be interactive. If you have questions, feel free to interrupt at any point. If anyone on Teams has questions, I think we could hear you. You're all muted. But first, I think history is important. I like to just give some history. Anyone know when the first successful IVF happened?
1978.
1978, yeah. So the first baby born through IVF was named Louise Brown. She was born in the UK, 1978. And there's a Netflix movie called Joy, and it's mostly true. It's like based on a true story kind of thing. And it tells like a story of the scientist Robert Edwards, who won the Nobel Prize. Patrick Steptoe was the gynecologist that helped him back then. They didn't have ultrasound like we do, which I'll describe. And there was also a nurse who was the first embryologist, and she passed away. She didn't get the Nobel Prize, but she's featured there. So it's worth watching. It's a movie. The interesting thing was that took more than 100 attempts before they finally had success. So that just shows how passionate people are. This was something new that had never been done. And women were lining up to do this experimental treatment because they really wanted to try to have a baby, and that was the only way. And over 100 times didn't work, and they kept trying and trying. I think after 40-something tries, they had a pregnancy, but it was an ectopic pregnancy. Then in the US, there were doctors named the Joneses that actually, Howard and Georgiana Jones, they were at Johns Hopkins. They had to retire when they were 65. In their retirement, they went to Virginia and started the first fertility practice in the US. And they worked closely with this Dr. Edwards in the UK. And they did the first successful IVF. And one of the things that kind of changed there was the use of gonadotropin. So the first attempts were very inefficient because they're working around a woman's natural menstrual cycle, trying to retrieve one egg, fertilize it in the lab, make an embryo, transfer it back. Didn't have the same medications we have. So now we'll get to a little bit of timing, antagonists, triggers, trying to make sure we have egg retrievals, you know, at 8:30, but a woman might be ovulating at 2 a.m. So they'd have to, like, back then have other methods and do these procedures that, you know, if they're off hours. So it's a lot more challenging. So adding stimulation was a big innovation because the process we know is not even in normal fertility, natural fertility. You know, again, we think that peak fertility is roughly 25%, that couples that are trying to conceive and fertile, maybe 1 in 4 months, everything lines up, and that gets lower as we get older or if there are other challenges. So even when we get multiple eggs in IVF, there's a lot of steps that have to happen. Being able to get more than 1 egg was a big innovation. We'll get to that. So that's some history. Now, if I think about IVF, like, I think it's good to know, like, why do we do what we do? So what are some indications? I think, you know, not everyone maybe needs to do IVF. There's different opinions, but we do other treatments like timed intercourse, intrauterine insemination, and those can work, surgeries. So what are some reasons, like, why we do IVF? Especially think about, like, what's the reason why we have to do IVF? Like, that's the only option or the way to go. Okay.
Like low sperm count.
Okay, that works in the andrology lab. So male factor. Usually in those cases, what's the treatment?
We process their semen, we give it to embryology, and they'll select one sperm and do ICSI.
So ICSI is intracytoplasmic sperm injection. When was ICSI first done? Back to history.
It was by accident, probably.
Kind of, yeah. So originally those women in that movie that you may watch on Netflix, most of them weren't really male factor. Now this is true. In the early days of IVF, you know, ICSI wasn't developed. IVF was getting egg or eggs, mixing sperm and egg, but there's very, very few sperm. Fertilization wouldn't happen even in vitro. What is in vitro? That means like outside the body. I think in vitro maybe flats or something. So like these are glass dishes. It's really like in a dish versus in utero. In utero is like in the uterus in the body, right? So fertilization or other fertilization actually happens in the fallopian tube. But in vivo is in the body. In vitro outside the body. So it's true, like if the sperm numbers are so low, or what's it called when we get like surgical sperm, all that, and if we realize testes, testicular sperm extraction, there's micro testes where there's microscope to find tubules to dissect. There's other abbreviations, there's PESA, which is a percutaneous MESA, PESA, but basically, like these weren't even really viable options in 1978, early 1980s. People were then working. Also, there were situations where even if the sperm numbers were okay, nothing would fertilize. And that was a challenge in the 1980s. So, as Alberto said, by almost accident, they were working on other ways. There's like trying to put the sperm closer, like under the shell, subzonal dissection. There were different techniques that weren't working so well. And then someone injected the sperm, and lo and behold, fertilization happened. They didn't. I mean, again, I don't know what would happen now with like IRVs when they had those, but if someone maybe never had fertilization before and fertilization happened, an embryo developed, and then they decided to transfer, but they didn't know that it was safe where you could just inject the sperm. Because in fertilization, typically many sperm will like bind the shell of the egg. One will be the one that actually fertilizes and gets through. we're kind of bypassing that, injecting the sperm. Now, after the early 1990s, that became more studied and applied. And so this was in the early 1990s. So it's more than 30 years now. Now it's pretty standard. Some clinics do HC intracytoplasmic sperm injection 100% of their IVF cycles. We don't, but nowadays this would be if we have like obstruction and you need a urologist or very low sperm counts. That would be a reason we might skip everything else and go straight to IVF and HC. But why do you think that the patients that were lining up to be the first ones to do IVF, why do you think they were getting pregnant naturally and needing IVF?
People in their fallopian tubes are blocked.
Good, yeah, tubal factor. So that's actually maybe a good prognosis for IVF. We know, as we know there's sometimes egg quality factors, sperm quality factors, age-related changes. So as we get older, we still think that all the eggs that someone is born with are there and they gradually get used up. The ones that are released later in the 30s and 40s age group are more likely to mature divided chromosomes with an abnormal number, result in eggs that can't make a healthy pregnancy. So, but someone in their, say, 20s age group still has good egg quality, but if they had like an infection, if they had ectopic pregnancy and the fallopian tubes were removed, endometriosis that could sometimes be really severe and affect the fallopian tubes. If they would try surgeries, they still sometimes do, but both fallopian tubes are removed because ectopic pregnancies rupture those tubes. There's really no surgery, until IVF, those patients wouldn't be able to have a child with their eggs. They'd have to adopt. So tubal factor, if it's really both tubes are blocked, how do we test for that? HSG. What's HSG? We use a lot of abbreviations here. Hysterosalpingogram. So hysterosalpingogram, if we think about the anatomy, this is the cervix, the uterus, has this kind of triangle shape, and then fallopian tubes. There's
People give out other colors.
That's okay.
I'm just thinking of people at home may not be able to do that. That's all. It's okay.
Yeah, we could take a picture and show it.
Okay.
Yeah. Little follicles, and we think a girl may be born with like 2 million tiny follicles, primordial follicles. We can't see them, but they're recruited over time and they fill with a little bit of fluid. Then they're called antral follicles. Those are the ones we can see on ultrasound. Those are the ones that will be recruited to mature to ovulate. So an HSG involves like a radiologist or sometimes gynecologist or reproductive endocrinologist. Places where PI, I think, that's on them, where she used to wear, places a catheter, injects a dye through the uterus. If the tubes are open, the dye will travel through and spill out, and they'll take X-rays and see where that dye travels. If the dye, sometimes there'll be like a spasm, it's a muscle. This is called proximal. This is distal, like close to the uterus, far from the uterus. Proximal occlusion sometimes is not really like, so some of my phone, their tubes are blocked and it's a miracle, I guess, pregnant phone. But maybe their tubes weren't really blocked. Maybe there was just like a spasm, and sometimes we repeat it and it's open. Some radiologists, like the one a lot of our patients go to, can place a catheter and maybe force the dye through with a little bit more pressure and really show that it's open. But distal occlusion, that's more likely real. Like if the dye travels all the way through to the end, why wouldn't it come out at the end? Probably because the end is blocked off. Again, surgeons can go in and try to open it, but it's not a very good prognosis. If they reclose, the tube may be abnormal inside and more prone to ectopic pregnancy. So this tube could be blocked, could be swollen, an ectopic pregnancy implants in here. sometimes we treat that with medication, but sometimes it bleeds, it ruptures, and that tube is damaged or has to be removed. So that's a clear-cut case for IVF. What else?
No ovarian issue.
So low ovarians are, that's a good point. Not necessarily, again, theoretically, like, we think back to the menstrual cycle, what happens? FSH is follicle stimulating hormone, right? It's made, it tells one of these to grow. That follicle matures, becomes dominant. Eventually there's an LH surge. LH surge happens, the egg is released. So if someone has a low ovarian reserve, sometimes we call it diminished ovarian reserve, we can tell that by antral follicle count being low. It's low, like less than 6 or 8, less than 4 would be low. AMH is a hormone, so we draw this blood test. These follicles make AMH, less than 1 is considered low. But it's expected to change with age, so there's kind of what's normal for any given age. So, is diminished ovarian reserve a reason to go to do IVF? Sometimes it's presented that way, but not an absolute reason, because you could release an egg and it's a good egg and everything lines up. But the challenge, especially if someone wants more than one child, nowadays we've gotten so much better in the lab at growing and freezing and genetically testing the embryos that, that maybe they get lucky and release a good egg and get pregnant naturally, but will it happen again in 2 years if they want a second child? Will it happen again in 4 years if they want a third child? And then this diminished ovarian reserve only gets lower and lower. So then they need IVF later, and it's going to be even more difficult. But also, IVF success, we'll get to, hopefully, although we don't have so much time, is very much related to like numbers. So the more eggs we get, the more embryos, the more chance of normal ones. So this is like a challenge for us as doctors. Sometimes a patient, gets diagnosed with diminished ovarian reserve. Some clinics will say that you have to do IVF. Then they might struggle and get only 1 or 2 follicles growing and not have success, and maybe one of those other treatments might have worked. So that's kind of an individualized decision. But not an absolute reason, but sometimes.
The current, what do you call them? When natural abortion, genetic diseases, sex selection.
Yeah, so there's a few things there. So one, I'll just lump into genetics. And that's somewhat newer. When first IVF was coming along, and just getting eggs and sperm together, making fertilization happen in the lab, that was challenging enough and didn't know if it would work and was controversial, and there'll be a whole nother discussion ethically, like people didn't know, would there be effects on the babies, the children? Now we know, Louise Brown is 47 years old. She had her own child naturally. There's been, maybe 10 million babies born through IVF. The vast majority are healthy, but that wasn't known and it was controversial. Different religions, had different views and things. But Bob Edwards, again, this scientist, even like the 1960s, envisioned that we could use this to, select, say, there are certain conditions that are like X-linked that boys are more likely to get. A kind of vision, we could select the sex and prevent having that disease. Now we've gone way beyond that. So we do our checklist, what's included in our checklist usually for genetics.
The tariff.
The tariff brand, it's a company. We call it generally now expanded carrier screening. So basically we test couples before they even, they may have been trying for a while, maybe not, to see if they carry any genetic conditions, like recessive conditions where they can be healthy, but they have a 50-50 chance of passing a recessive variant or mutation to the egg, to the sperm. And then there's a 1 in 4 chance any given embryo would have that, both copies of that variant and have a disease that maybe was never in their family. So then they have options. We have genetic counselors that we work with. They can either, depending how severe that condition is, they could try to get pregnant and test the pregnancy or test the baby, or they can make embryos, and we work with a genetics lab to do what we now call PGTM. It used to be called PGD, pre-implantation genetic diagnosis. Now PGTM, what's the M? Monogenic disorder. Or SR is structural rearrangement. There's something called a translocation, where it's like rearrangement, either 2 chromosomes fused together, a piece of 1 chromosome broken off and attached to another. But basically, they're more prone to having, anyone without any of these genetic conditions. There could be a new mutation that just happens out of the blue. That's called de novo, a de novo mutation. We can't yet test. There are companies and labs looking into that. Controversial. The type of testing like we do at Juno, the labs we work with, can't test for every mutation. But it could be targeted if we know that the couple both carry a variant for, say, Tay-Sachs, which is a very severe enzyme deficiency that babies would die from if they don't get a normal copy of the gene. They can test the embryos and predict which one will be a carrier, like the mom to dad, which would be half of them, which would be not even a carrier, which would be a quarter of them, and then a quarter by chance would be affected. That's just on average. There are couples that before PGTM would have a child that would have Tay-Sachs and die, another child with Tay-Sachs. So screening before is helpful. Expanded carrier screening. Structural rearrangements more often cause miscarriages. So recurrent miscarriage or recurrent pregnancy loss, that's kind of a controversial one. It's not typically considered like if you see a couple that has 3 miscarriages, they're getting pregnant at home, do they have to make embryos in the lab? If we know that those miscarriages are due to something called aneuploidy, which Dr. Karipchin might have spoken about on Tuesday, then you can do PGTA. I saw a patient yesterday that their first pregnancy, they had a miscarriage. They didn't test it because it was just the first time. The second pregnancy, they actually have a baby. Then they had a third pregnancy miscarriage. They tested. They had monosomy X. That can result in Turner syndrome, but also more likely to stop development. Next pregnancy, trisomy 16. That's another common chromosome abnormality found in miscarriages. So, again, there are like randomized trials taking hundreds of couples like that and saying if you try naturally versus you do IVF and make a normal embryo and transfer, but it's become at least an option to say, if you get pregnant naturally again, you might get lucky, but you might not. If we can make a normal embryo, at least we'll know from the beginning that it's almost definitely not gonna have one of those chromosome abnormalities. So in general, patients with recurrent pregnancy loss should have an evaluation. Maybe they have a septum in their uterus. Maybe they have hypothyroid. Maybe there's something else we can change, or maybe we don't know, but we don't know that just putting a normal embryo will fix that if there's something else, right? So in certain situations, maybe, especially if it's due to a structural rearrangement, translocation, or maybe like repetitive aneuploidies. But definitely the PGTM, we can take the risk from 50% for a dominant condition or 25% for a recessive condition down to like less than 1%. Any other reasons?
Maybe if someone had a hysterectomy, doesn't have a uterus, they still want to have kids, they can use a gestational carrier.
So gestational carrier, which more generally, third party, right? If we're using also donor eggs, like we have to get eggs, make embryos in the lab. So in certain situations, if someone goes through menopause, either prematurely or at a natural age, or we've done IVF, we've tried treatments and we're not able to make viable embryos, egg donation is an option, but in order to do that, we have to do IVF. If someone can't safely carry a pregnancy, either they don't have a uterus, they have a medical reason, we have to make embryos outside the body. That's good. That's a good one.
The same-sex couples or single parents?
Yeah, so in same-sex male couples especially also have to use a gestational carrier. And same-sex female couples, well, you can use donor sperm. Yeah, sometimes we'll go to IVF, but not an absolute. They can often try IUI and do really well there.
Right.
I mean, all of this actually is probably male factor is a big portion of our patients, but a lot of our patients actually don't fall in. It's like, like tubal factor is a pretty small population. Genetic, we do more and more, but
You also have like fertility preservation for like,
yeah, that's good. If we're going to preserve fertility, either quote unquote lactively because
Or-
someone doesn't have a partner, the only real option we have is to get eggs and freeze eggs or make embryos if they're a couple and they're not ready or it's not safe to be pregnant for years into the future. Or they get diagnosed with cancer, that's something, onco fertility, or some other medical condition where the treatment, we know with time that egg supply is going to decline, the egg quality is going to decline. But if you are exposed to something like chemotherapy that affects the germ cells, the eggs, or can be sperm, that will deplete that supply, and they're more prone to early menopause. Also, they may be told not to get pregnant for years or go on certain therapies for years. So fertility preservation, that's a good one. We almost, the one I was kind of getting at, like, it's not an absolute, but if we try, everything else, basically, what you call it, unexplained infertility, then now, again, that we've gotten so good, thanks to everyone here and our whole team, that we do really well with making embryos and freezing, that it's paradigms have changed where it used to be, and technically infertility is trying to conceive for a year, not getting pregnant. And we say if it's been 6 months over age 35, it's reasonable to do evaluation after 6 months. Sometimes we do it sooner than that. But we know in certain situations, like if a couple married at age 40, but they're not 2 children, even if they're fertile or really infertile, natural fertility declines, so it might be difficult. Even if they do have a natural pregnancy, like I said before, will they have a second natural pregnancy 2 years later? Maybe, but if not, our IVF success gets lower and lower. So some will go directly to IVF even before trying, or some will try and then do this evaluation and they don't have severe male factors, they don't have tubal factor. And it's a decision, do we try IUI and how many times? Again, traditionally we would try IUI maybe 3 times, and sometimes it would be 6. Some insurances used to require even 6 IUIs. For same-sex couples, they would say they're not infertile, they might make them try for a year with donor sperm IUI. So they're different kind of paradigms. Here, typically 2 or 3 IUIs. We at least discuss IVF. Some people will want to do more, especially again, as age is a factor. There was a study like many years ago that looked at cost efficacy. IVF is much more expensive than IUI. But if you do IUI again, again, and again, and it doesn't work, and then you do IVF, you spend more time and more resources. So over age 38, it's probably cost effective, for insurances if they're covered. So some of them have become more liberal about letting people skip the IVF quicker, or if someone is figuring out what's the best use of their time and resources, it's acceptable. You don't have to do IUI. But again, when we counsel people, it doesn't mean they couldn't have gotten pregnant some other way. IVF is just the most effective. So that's like why we do IVF.
What about, experiencing like hormonal issues when they can't produce the FSH, LH?
Yeah, so that sometimes comes up when I'll do this last year, next year. Sometimes people will say like PCOS is one example. That's similar to DOR. Like sometimes it gets to that, but not in absolute. Like if the anatomy is normal, if everything else is normal, if we can help her to ovulate, she may not need to do IVF. So with PCOS will often start with like pills like letrozole or Forman, which kind of trick the brain to make more FSH so that if they have these follicles sitting there, but they're just not making it, but it's not as kind of good as nature, and there's not as much of this like feedback and forth. So sometimes they'll have 2 or 3 follicles. That's why we monitor. There's a higher risk of twins. If they have too many follicles, we might even cancel. There's another condition called hypothalamic amenorrhea where there's follicles, there's eggs, but they're not making FSH. Even giving those pills may not trick the brain, because those pills kind of make the brain think that estrogen is low, so it should make more FSH. But if estrogen is already low and that's not happening, it usually doesn't work. So those patients, we often have to give, there used to be pumps, GnRH, is gonadotropin releasing hormone. This is made in a part of the brain called the pituitary. This is made in the hypothalamus. This is the ovary, the HPO axis. There used to be, and there may be in some countries, and maybe a company trying to bring it back, a GnRH pump, like an insulin pump, that would make this pulsatile hormone, and eventually she would start to make FSH and ovulate one egg at a time. But it would break, it was even before my time. Now we may just give injections of FSH and some of this LH activity. One of our medications called Menopur, the early forms of these medications we use, we abbreviate HMG, human menopause gonadotropins. It actually, when a woman goes through menopause, FSH gets really high because now there's no follicles there, or very, very few. They're not making estrogen. And again, it's not that situation where the brain isn't responding. The brain will make a lot of FSH and some LH, some HCG actually, and it gets into the urine and it can be extracted and purified. So menotropin, Menopur, that's the medication that has FSH and LH, and we can make some of this, again, who's not producing these hormones, we can give their follicles what they need. But that's a fine balance. You have to give just enough so only 1 or 2 grow. Sometimes those patients, difficult to get them to only make 1 or 2, and maybe they just go to IVF and use a higher dose and get more eggs and make embryos, and their embryo don't have to do this month after month after month.
Don't they ferment? Don't they also give some of those so they can maybe restart sperm production?
So then for women, it's more of a cycle. If you learn the sperm production is not like a monthly cycle, but they do make these hormones FSH and LH as well. So sometimes Clomid is given to try to get more stimulation to make more testosterone, help with sperm production, or even like injections. Usually they'll get HCG because HCG is very similar to LH and has more of an effect on testosterone production, which is what is needed to make sperm. I don't know if we have a male summer school, but if the guy takes testosterone, that's like a negative, goes that will tell the brain not to make that, and then they'll actually make less of their own testosterone where they need it,
for the sperm production. So if a couple's trying to get pregnant, the male partner should not be taking testosterone. It will actually make their sperm counts go down, and then they'll be over here. But if they are not making enough of their own testosterone, they can take HCG to try to boost that. So a little over time, but obviously this is an important topic we do every day. So I'll take maybe like just a couple more minutes just to like show what actually happens in IVF. So now, like I said, we move to stimulation. So basically, instead of just enough FSH getting one follicle to grow, or Clomid getting maybe 2 follicles to grow, we give injections of FSH, which we have Gonal-F and Follicin. Those are 2 brands. There may be another one coming eventually that we were a study site for, on Vacavelle from Ferman. These are recombinant. It means like gene technology to make cell lines and just pump out like pure FSH. Versus this is human derived. Women in South America that are menopausal will collect their urine. Ferry Pharmaceuticals collects it from them, extracts these hormones from their urine, purifies it, gets it into a powder, and that's manufactured. Also, hopefully, they'll have a liquid version that's supposed to come out now. You have to like put this liquid, mix the powder, dissolve it, and inject it. But a liquid Menopur pen is supposed to be coming at some point. And so we give usually both of these so that now, again, we can't make new follicles, we can't make new eggs, but we give more of these follicles a chance to mature and grow. When we do our morning monitoring, we have a transvaginal ultrasound probe that can see, usually always sitting right there. And they grow, these follicles as they grow into estrogen, estradiol, the main hormone. We also check LH to make sure they're not breaking through and going to ovulate them. They make progesterone, we check that as well. It can have an effect on the uterine lining. The uterine lining will thicken as estrogen is being made. We measure that. We measure these follicles. Usually when the follicles get to be like a 15 to 20 millimeters in diameter, they're more likely to have a mature egg. We give a trigger shot. So before that, we give something called the GnRH antagonist. Whoops, that blocks this from happening. We don't want that natural LH surge to happen and ovulate before the egg retrieval. That happens occasionally. That's obviously really sad that we're expecting 10 eggs and then they ovulated. So in the early days, they didn't have those options. Now we have more medications or different strategies. We have our protocol and the protocol, but a lot of it's designed to stimulate and prevent ovulation until we trigger. When we trigger, we want to kind of mimic the LH surge. There's a medicine called Lupron or Leuprolide that acts like GnRH that tells the brain to make LH, and we measure LH the next day. Or again, HCG is very similar to LH, but it stays around longer, has a longer half-life. So we give those trigger shots, and that actually would make these eggs ovulate. So if the patient doesn't show up for the egg retrieval, eventually hours later, she's going to release those eggs. But we want the egg inside the follicle to mature genetically so it can combine with the sperm eventually. We want it to loosen from the follicle wall and fluid so that we can retrieve it. Then this ultrasound probe has a guide, a needle that you can see, and the needle enters through the vaginal wall into the ovary, into each follicle. And again, we see that on ultrasound. We have tubing that we control with a foot pedal, and the fluid gets suctioned through, gets handed off to the embryology lab, and they search and they find the eggs still surrounded by what are called cumulus cells, like cumulus clouds, and puffy. And then we could do whatever else we're going to do. And I think Dr. Kustis is going to give a talk at some point. We can clean away those cumulus cells and freeze those eggs that day. We can inject one sperm if we're doing HC. We can mix sperm with those cumulus oocyte complexes, COCs, and see if fertilization happens the next day. That's how we get the eggs in the lab. think I'll stop there. It's a little bit over. Any questions? Question? No? Question? Yeah?
For the male factor, how do you guys determine the patient has a low, like, for the semen analysis? Do you look at the morphology, the motility, volume?
So semen analysis, so there's multiple parameters that are included. The volume of the semen, that can vary a lot from day to day. That's not so predictive because you can have a normal volume, but if there's not sperm in that volume, like you have to look at the microscope. So then with a microscope, or we have something called like lens touch, a cartridge that will count the actual sperm. So it actually looks at like sperm cells, estimates the concentration and the motility. Those are the two most, I think, predictive parameters. So the concentration is how many millions of sperm per milliliter. Normal has changed over the years with different criteria. It used to be 20 million, then it was 15, now it's 16 million per ml. That's like the lower limit of normal. And then motility of those tens of, so there could be 30 million per ml, 2 milliliters, that's 60 million sperm. If 50% of them are moving, that's 30 million moving sperm. So there's like motility. It's normal for some of them to not be moving, but a good proportion, about a third at least, should be moving forward, or more than 42%. That's normal. WHO says for at least 42% should be moving, and at least 32% should be progressively moving. But I mean, again, these are based on prior studies of fertile couples. So morphology is the shape of the sperm, and a lot of them are abnormally shaped. If you look, you have like a picture of a perfectly shaped sperm with an oval head, and neck and tail, a certain appearance. And that has changed also and become stricter, and even 4%, so 4 out of 100 being perfectly normal is considered good and fertile. But that can vary a lot from lab to lab, and I think less predictive of like natural fertility. If someone comes in and their concentration is very low, like less than 5 million, yeah, it's not impossible to get pregnant naturally, but it's very predictive, and it's unlikely if it's consistently. That's not just a once we should repeat it. It's consistently like that. And IUI is not a great option because for IUI we usually want at least 5 million moving sperm, but if they're starting with only like 5 million total, and a lot of them aren't moving, and then we wash them, we're going to have less than 1 million moving, placing them even in the uterus closer, usually, still not helping enough to get as many as we need. Basically, we need like a lot of them here at the time the egg is released and ready to be fertilized, and even putting it here, so the success of IUI is going to be very, very low, and we usually just skip directly to ICSI.
So is it safe to say if we look at the semen analysis, if the concentration is below 15 million milliliters?
When that's abnormal, then that's an indication to say, like, I've repeated, maybe see a urologist, see if there's anything they could do. But that would be reasonable to say that's oligozoospermia, low sperm count. That's an indication to go directly to ICSI. And if someone, they don't want to do IVF, they can try to work with urologists and improve it. We're flexible, we counsel, we can try IUI. It's just probably not going to work. And that's where it is. And if AMH and egg supply are good, and we spend 3 to 6 months doing that, and then they do IVF, chance of IVF working is pretty similar. But if you're 40 and you spend 6 months, a year doing that, and then you do IVF, it already was difficult. It's even more difficult. So some people have things to do at 12:30, so feel free to leave. But
I need your signature for Mary.
okay.
She's here.
Any other questions?
Yeah.
So after fertilization, I know there's like day 3, day 5. I still don't know, like, I feel like a reflection of how the timeline happens after fertilization.
Well, I think maybe do this first. Yeah, I think you can say after, so, okay, you check for that, but, so, okay, so Dr. Kustis is gonna give a talk as well and show embryo scope images, which is really cool. But like the menstrual cycle, you can hear this multiple times and keep learning. So anyone again that wants to stay for a few more minutes, basically, once we get the eggs and sperm in the lab, we find them either by injecting sperm into mature egg or mixing good quality sperm with eggs, then checking the next day. How do we know if fertilization happened?
For nuclear formation.
What?
For nuclei.
Okay, so the egg will be its big cell that has a shell around it called the zona pellucida. If it's mature, how do we know it's mature? It extrudes something called a polar body, basically like divides, those 2 copies of the chromosomes. It keeps 1 copy and it gets rid of another copy. So this is something called meiosis. You can look up and read about lectures or whole classes on it, but like the sperm, like the germ cell, the spermatogonia, actually like divides and becomes 4 spermatids. But the oogonia like becomes 1 mature oocyte or egg. It discards half of the chromosomes at ovulation or the LH surge, the trigger. So if they don't see a polar body, it's not mature, they don't do ICSI, sometimes they look the next day, day 1 ICSI. Then, again, with a regular IVF, we may not see that, we just check the next morning. It goes through the second meiosis 2, because there's like 2 copies of each chromosome and they each have 2 chromatids. So 1 goes into the first polar body, and then at fertilization, these separate, and 1 goes into the second polar body, and it should keep 1 of each chromosome. And the sperm, that's called a haploid cell, has 1 copy of each chromosome, 1 chromatid. The sperm, they're actually the ones that look normal are more likely to have gone through meiosis correctly, even if the guy is much older. So even if the guy's in his 40s or 50s and they're using donor egg, 90% of the embryos we test are normal, because other things can change with age, with sperm, but the chromosome number is usually correct. So then it extrudes a second polar body. Sometimes it's fragmented or hard to see, but then emerges something called pronuclei. And there's like the DNA, the genetic material from the sperm, from the egg. So there's 2. So 2PN, that's how we abbreviate. That's normal fertilization. But this is an evolving narrative. We have changed this field, and we've presented research. Like sometimes we look and we don't see the pronuclei. We know they then fuse, well, syngamy, and then disappear. And so you don't see. So that's why timing is important in the lab. They have to know when they do ICSI, and something like 16 hours later, you do fertilization check. If they do the fertilization check too late, they forget. That's why it's also really important to have charts and checks. If they forget, oh, we missed that fertilization check. They go, at noon instead of 10 a.m. They may have missed it. The pronuclei are gone. But now we have this cool thing called EmbryoScope where they can just like rewind and see what happened. So the Kustas will show you. But even at the right time frame, like there's always variation. Sometimes it looks like it didn't fertilize, but it really did. Sometimes there's 1 pronucleus, sometimes there's 3 pronuclei. Those are considered abnormal. So then it becomes, these are gametes, sperm and egg, comes together. It's called a zygote now. It's a new embryo. Now again, the chromosomes make this new unique embryo. And then it's not meiosis anymore. Meiosis is only the germ cells, the sperm, the egg.
sexual reproduction. Now it's mitosis. Now it copies itself exactly, hopefully, and makes like a new daughter cell. And so divided into 2, 4, 8 cells. So day 3, that's called cleavage. Some of them just will not divide. That's rare, should be maybe 95%. We have embryologists in the room too. Over 90% should cleave.
The normal patient.
Yeah, and sometimes we don't see. So then on day 3, it's about the same size actually. So this is kind of the egg, the sperm. The sperm is the smallest cell in the body, and the egg is the biggest cell in the body. The sperm is mostly just DNA packaged. The egg has all the cytoplasm, mitochondria, organelles that are involved in this early embryo development. So then this embryo now still has that shell around it, and it has like individual cells, maybe 6 or 8 cells inside. Then we sometimes do something called assisted hatching. They take a laser and they make a little opening slit. But naturally, there would be like enzymes that would happen. This embryo would hatch out. This embryo has to come out of its shell to implant. But it becomes a little compact ball of cells called the moria. So this is day 3. We don't even look on day 4 traditionally, but now with EmbryoScope, it's taking pictures every 10 minutes and we can see what happens. It becomes a morula, which is just like in these individual cells, compact, you can't even see the individual cells anymore. And then a fluid cavity forms in the middle. That's called the blastocele. It's a blastocyst differentiates as a part that becomes the inner cell mass, and the outer part that becomes placenta, the trophectoderm. And it might start to hatch on its own, or if we made this hatch, some of these cells will start to hatch out. That's what they biopsy, the trophectoderm biopsy for PGT. This is the inner cell mass, not HCN. When we give the grades, there's like an A, B, C, APC. So a good quality embryo, AA. If it's expanded, it's 4. There's numbers again, but I don't want to go too much into it. That's basically the embryo development. And these could be frozen and thawed. These could be transferred into the uterus.
So we biopsy on day 4, the GT biopsy. With the,
No, day 5, 6, or 7. So it becomes a full blastocyst that is expanding, has this well-developed trophectoderm that's starting to hatch out. Well, there's different methods of it. They can biopsy on day 5 and freeze. If it's still early, we'll check it on day 6, and sometimes even day 7. But we used to not even look on day 4. It would be unusual for it to be that early to be a blastocyst. The biopsy on day. There are places that biopsy morulas, and we don't. Days of day 5, day 6, or day 7. That's the days we biopsy or freeze. If it stops developing along the way, it's arrested in its development. It's not viable. Sometimes it's a blastocyst, but there's no inner cell mass. I don't think that's viable. Or the cells are degenerating. Like very few of them. So just because it becomes a blastocyst doesn't mean biopsy and freeze it or it's good quality. Some of them are just has the blastocyst can be, it's just not viable. Right, you should get back to work.
thank you.
And feel free to ask questions anytime. And you're welcome to like welcome to shadow ultrasound, consult, lab.